colleague has already considered defeat because he has spoken in favor of it is different. He has suggested so many things which ought to be done to ensure that women, diabetic women, do have different, they do not have different manifestations of cardiovascular disease. So I am going to contest this issue that do women with cardiovascular, are the cardiovascular manifestation in diabetic women different or the same? And I would very emphatically say they are not different. The core argument I would like to say is that diabetes basically is a powerful gender equalizer and a risk neutralizer, and that overrides the gender specific differences. Once a diabetes develops, it does not see whether it's a man or a woman. Have you ever heard that a diabetic woman has got different set of coronary ischemic heart disease? Do you ever know that a diabetic patient has got a specific, a diabetic woman patient for that matter, has got a specific disease pattern and specific drugs to treat her ischemic heart disease? Do any international guidelines have separate stipulated protocols for management of women with diabetes, with cardiovascular disease? The answer is significantly no. Then what is the problem? The main problem is, in 2026, when scientific consensus strongly emphasizes that diabetes affects women's cardiovascular risk, more than men's cardiovascular risk, but the researchers also emphatically say that there is no difference in the counterpoints. The reason is there is no absolute risk, and when we come to absolute risk and treatment outcomes, absolute risk of having coronary artery disease and the treatment outcomes in women, it is similar. The risk for specific cardiovascular elements, it is similar. The socio-cultural and gender bias, when we talk of, that is the principal factor we have to lay stress upon while debating this issue. We all know women and men, they equally suffer from the same set of cardiovascular disease like coronary artery disease, myocardial infarction, stroke, PADs, heart failure. It's seen equally in both the sexes. The pathophysiology underlying the process of cardiovascular disease in men and women does not differ significantly because the problems contributing to ISDs, chronic hyperglycemia, insulin resistance, stress, oxidative stress, accelerated atherosclerosis, I mean all these are basically pathophysiological culprits which are contributing to serious disease in men and women. They are basically sex neutral. If you consider the risk factor clustering, both the sexes show hypertension, diabetic dyslipidemia, central obesity, and pro-inflammatory status and pro-thrombotic status. This does not depend upon the gender difference. The clinical syndromes we see in men and women, they are STEMI, non-STEMI, stable, unstable angina, ischemic stroke, HFrEF and HFpEF. No female-specific diabetic cardiovascular outcomes really, and diagnostics are identical. Same ECG criteria for females, same troponin thresholds, same angiographic definitions, same echocardiographic parameters. Where is the difference? The answer to this would be the treatment guidelines. If we consider same statins, ACE-ARBs, SGLT2s, GLP-1 receptor agonist, antiplatelets, no sex-specific discrimination in therapeutics as well. Absolute risk and treatment outcomes, if we consider, secondary prevention studies show that statins are also equally effective in female population, and underlying biological response to primary treatment does not differ significantly in both the sexes. Similar risk from diabetes duration. Large scale data from 20 to 25 indicate that duration of diabetes increases cardiovascular risk nearly equally in male and female population, that is approximately 20% for 5 years. Stroke and heart failure consistency regional registry from 2017 to 2026 also show no significant safe difference in excess risk of stroke or heart failure associated with type 2 diabetes in different sexes. Parity in advanced complications, the similar complications in men and women at later stages, sex-specific differences may be overshadowed by the disease overall burden. Then what comes very important to play a role is the socio-cultural gender bias or biological sex. Women with diabetes are statistically less likely than men to receive guideline recommended therapy, including statins, aspirins and ACE inhibitors, which may falsely inflate their biological risk of ischemic heart disease or coronary artery disease. And needless to say, there are distinct diagnostic delays when it comes to female population, because observed worse outcomes in women often stem from atypical symptoms presentations leading to delayed diagnostic criteria rather than a different set of biological manifestations. Manifestations basically remain the same. It is the delay in the diagnostic criteria and diagnostic rapidity. Underrepresentation in research. Many of the long-term follow-up studies which you find, or the trials which are conducted, they lack women in clinical trials. Historically, the lack of women in clinical trials mean current standard diagnostic criteria like troponin threshold, they were developed primarily for men and may be simply miscalibrated considering the female's physiology. There are several maladjustments of risk factors when we come to male and female population. So clinical implications of all these things is that if we try to screen the female population early for cardiovascular risk factors, if we also try to consider pre-diabetes or coronary cardiovascular risk factor in female, if we try to address the diagnostic delays in females, and if we try to have a good therapeutic access and combat therapeutic problems of these patients with the earlier institution therapy, and try to set therapeutic targets same male and female by early and aggressive intervention like LDL and BP control, and ensure statin and ACE utilization in practically every woman, then perhaps we would not find these differences which are projected. So the research, what actually the research needs is to mandate 6 stratified trial data rather than having this tossed up this question like females have got a different cardiovascular manifestations, and we should also consider the female specific mechanisms for contribution of ischemic heart disease. So to conclude, I would say diabetes produces a uniform cardiovascular phenotype. Diabetes is a powerful cardiovascular risk factor that overrides gender specific differences. The difference lies in recognition of cardiovascular manifestation in females and not basically the manifestation. The difference lies in recognition of the risk factors in females. We do not detect the risk factors early. We do not treat them early. We do not diagnose and identify the high risk individuals early. But the manifestations are absolutely same. So my verdict would be strongly no. The manifestations, cardiovascular manifestations in diabetic women are not different. They are essentially the same. What you need to do is to early identify and give aggressive attention to the females also for identifying coronary artery disease. Thank you very much.